Hello, everyone, and thank you so much. Thank you so much for inviting me to speak with you today. Oops, I kind of lost my, maybe I hit return. There we go. Okay. Thank you so much for inviting me to speak with you all today. I'm really looking forward to sharing some information with you and then having a discussion at the end of this. So as Melissa said, I am Dr. Meghan Marty, and I'm a licensed psychologist. I've had a private practice in Southeast Portland for 5 years now. I primarily offer psychotherapy and focus specifically on working with folks age 60 and older. I certainly have worked with lots of folks with Parkinson's or caregivers of people who have Parkinson's over the years. And I also offer different healthy aging groups and uh, discussions and workshops, and have a monthly newsletter all around healthy aging. So that's definitely an emphasis of my practice. And I supervise graduate students as well. I always love doing presentations in the community. It's a nice way to kind of give psychology away for free in a sense. So sharing the information I have as a psychologist. I do like to say just upfront that I am a psychologist, but I am not your psychologist. So all the information I provided today is just meant to be educational in nature and not to be psychotherapy or replace any information you might receive from your own healthcare providers. So for today, let's see if I can advance the screen here. Oh, there we go. Okay. So for today, we're going to talk about some common mental health concerns. We'll talk about when it might be useful for you to receive some professional help from a mental health clinician and how to go about getting that help. And then just a little bit about what to expect from psychotherapy for folks that may not have experienced psychotherapy so far. So the first mental health concern I wanted to talk with you all about today is social disconnection. So there's kind of two parts of this that we look at in psychotherapy and in the research literature as well. There's two parts of it. The first one is social isolation, and the second one is loneliness. And this certainly has been common during the past year and a half or so that we've experienced COVID. So social isolation is considered to be they're distinct experiences, social isolation and loneliness, but they can occur independently of one another as well. But again, they're both characterized by social disconnection. But social isolation, we consider that to be kind of an objective measure of someone's social connection. So how many friends or family members someone is in contact with, how often they're in contact with those folks, availability of being able to interact with the social network and take advantage of resources in the community. Whereas loneliness is considered to be more of a subjective experience. It's kind of our perceptions or our felt sense of connections to other people. And this loneliness can really happen when there's a discrepancy between preferred and actual level of social contact. So you can imagine that someone might be in a room full of people that maybe they don't know very well. So they're literally surrounded by other people, but maybe feeling lonely if they're sensing a lack of connection with those other folks. You can imagine the opposite as well. Maybe someone goes on a camping trip alone in the mountains and they feel perfectly fine being all alone. They're not feeling lonely at all. So again, that's kind of the subjective sense of social connection. And these are really important because the research has found that lack of social connection actually has really serious potential implications for our physical health. So they've found that social connection is as important to our physical health as things like smoking or being overweight or physical inactivity, alcohol use, all of those things that we kind of know have an impact on our physical health. Social isolation and loneliness are as much of a factor, if not more, than some of those other things. A study that was done previous to COVID found that approximately 25 to 29% of Americans aged 70 and older reported that they were lonely. And there were similar estimates in Europe and Asia as well. So it's not just a United States thing. And there's approximately the same incidence of loneliness across race and ethnicity and gender as well. So it's pretty pervasive. And again, a lot of that information came even before COVID and all the restrictions we have experienced over these past almost 2 years now. So the next common mental health concern I wanted to go over today is grief and loss. And when I talk about grief and loss, I'm talking about experiencing the death of a loved one, certainly, but I'm also talking about loss of one's own abilities. So things like changes in hearing or eyesight or mobility or memory, people can experience as losses and experience grief for, loss of independence or loss of control. And then I'm also referring to anticipatory grief for our own mortality. So, kind of anticipating our own death. Sometimes we can experience grief for that as well. And grief is a very natural, normal response to loss, even if it is uncomfortable or unwanted. It is a very, very common and very understandable and very normal experience. We often think of grief as just as a specific emotion. That's kind of how we talk about it. But it's actually made up of a number of emotional and physical and cognitive experiences. And I've listed some of those on the slide here. So I won't go through all of them. I will let you read all of those different factors on your own. But just to know that grief is a pretty complex experience. It is very individualized. So one person's grief doesn't necessarily look like another person's grief. In addition to some of these emotional and physical and cognitive experiences that we can have during grief, people might also experience spiritual or existential changes with grief. So, feelings of anger towards God, or feeling that someone's being punished or abandoned by God. Some of those experiences can be common in grief as well. I do want to note there is a lot of overlap between grief and depression. So if you look at these different factors, you'll notice when we talk about depression in the next slide that there's a lot of overlap between grief and depression, but they are two distinct emotional experiences. People certainly can have both grief and depression at the same time. But I mention this because it's really important, especially if you go into a healthcare provider, to let them know if you're experiencing some of these symptoms, to let them know if you've experienced any losses. Again, either the death of a loved one, changes in your own abilities, things like that. Because we don't have a prescription for grief, we do have very effective prescriptions and medications for depression, but not for grief. So if you go into a healthcare provider and say, I'm feeling really down and I'm having trouble eating and I'm not sleeping very well, it's really useful to let them know, I just lost my best friend of 50 years last week. So they're aware that grief is a part of your experience, perhaps in addition to depression. Sometimes I'll get people referred to me in my practice who have depression, but when we look at it, their antidepressant medication isn't helping them very much. And sometimes the case is that they're also experiencing grief, and that's explaining some of the symptoms that they might be having. And again, just want to emphasize that grief is a very personal and unique experience. There's lots of variation in kind of the frequency and the intensity of some of these symptoms that people might experience with grief. And it's really not useful to compare our experience to those of others. So just being aware of especially kind of expectations around how long someone should be grieving for, or how long I should be grieving for. Sometimes those expectations kind of add a sense of pressure or stress to our grief experience that isn't very helpful. So, a lot of times people will say, gosh, my husband died a year ago now, and I'm still really struggling with my grief. Something must be wrong with me. That's not necessarily the case, but if if someone is having concerns about their grief process, it might be useful to talk with a mental health professional about that. Another really important, one very important distinction between grief and depression is that grief tends to occur in waves, and particularly in response to reminders of the loss. So sometimes people will be feeling like, okay, I've got a good handle on my grief, and then all of a sudden it just feels like the intensity of their grief is just kind of coming out of nowhere. And very often when we look at it, there's some kind of trigger for their kind of increase in grief experience. So it might be, holidays, missing their loved one, or anniversaries of birthdays or wedding anniversaries. Those kinds of things can often kind of trigger more intense grief. So again, it tends to occur in waves. Um, and I think another big difference between grief and depression is that we can also experience positive emotions during grief as well. That isn't necessarily captured on this slide here, but when we reminisce about good times that we've had with a family member, sometimes we can experience joy and gratitude, even at the very same time that we are experiencing grief. And of course, grief and loss has just only intensified over this past year and a half as people have experienced deaths of loved ones to COVID or other diseases that aren't related to COVID, but just have happened to occur during the pandemic. I should have said in the beginning too, we have time for discussion at the end. So if you do have any questions, I would just encourage you to kind of jot them down so we can go back to your questions at the end of my portion of the talk today. So just a little bit about depression. Again, we kind of think of depression as a feeling, but when we talk about depression in terms of kind of mental health, there's emotional and physical and cognitive aspects to depression as well. So certainly changes in mood. One thing that's really useful to know is that sometimes for folks age 60 and older, they can experience depression a little bit differently than people might if they're in their teens or younger adult years. So a lot of times we'll see irritable or kind of agitated mood versus someone feeling just kind of low or down. But certainly feeling low or down is a common part of depression, as well as just not really being interested in activities that you might normally be interested in. And then certainly there's several, physical aspects to depression. I think one really important part, especially if you or a loved one are dealing with Parkinson's disease, is that it's sometimes there's a lot of overlap in experiences that you might have due to Parkinson's and depression. So it can be really helpful to have a mental health provider who has some understanding of Parkinson's and how it manifests, so that you can tease apart a little bit what might be depression, what might be Parkinson's, what might be a combination of both. One aspect of depression that I think is rather unique is the cognitive aspect of it. So a lot of times when people are really clinically depressed, they might feel kind of worthless, kind of hopeless, maybe feel like they're a burden to their family or friends. Those are always things that I'm looking at when I'm working with someone with depression, because they're usually a signifier of depression. But then certainly, you can have problems with concentration or making decisions. A really serious and very important thing to watch out for with depression is that people can have thoughts of death or suicide. And that is certainly a sign that someone is really suffering and really could benefit from some professional support. And clinical depression tends to be more persistent. So like, whereas grief kind of comes and goes in waves, depression usually kind of sticks with us. For the clinical diagnosis of depression, someone has to be experiencing a number of these symptoms consistently, at least for 2 weeks, and the symptoms have to interfere with their functioning. So that's kind of ways that we tell if someone is clinically depressed. And with the literature I'm familiar with, the estimates range from 50 to 60% of people with Parkinson's will experience depression at some point in their disease. So it's definitely something to watch out for in yourself or in your family member or loved one. So I want to talk a little bit about anxiety next. And again, there's a number of different emotional and physical and cognitive aspects to anxiety as well. And I think it's really useful to think about anxiety on a continuum. So all of us experience some amount of anxiety at some point. And again, certainly during the pandemic and all of the other things we've experienced during this pandemic, some anxiety and some worry is very normal and very understandable in reaction to everything that we've been dealing with. There is a difference between a little bit of worry every once in a while that someone feels like they can kind of handle versus a full-blown panic attack, which might feel sort of out of control and not able to handle very well. So again, it's useful to think about anxiety kind of on a continuum. Um, and it's also useful to know there's a lot of different medical disorders that can kind of look like anxiety. So again, it's really helpful to have a mental health provider who has some understanding of medical conditions that kind of might look like anxiety. So things like hyperthyroidism, asthma, hypertension, atrial fibrillation, some of those pretty common medical disorders has a lot of overlap with anxiety. So it's really helpful to be aware of again, what might be anxiety and what might be something else going on. And again, for a clinical diagnosis of an anxiety disorder, we really look at, are the symptoms really interfering with someone's ability to do their daily activities or interact with other people. And the estimates that I've heard of are up to about 40% of people with Parkinson's will experience some form of anxiety, again, at some point in their disease process. So again, I think, people generally tend to be aware of depression and how that can show up with Parkinson's, but anxiety is a pretty significant thing to watch out for, again, in yourself or your loved one as well. So just to say a little bit specifically about COVID. So there's been actually several studies looking at emotional well-being during the pandemic. And the study I'm referencing here was kind of a study that looked at a bunch of studies that took place all across the planet, people all different ages looking at emotional well-being during the pandemic. And in general, most of the studies suggest that older adults have lower levels of stress, post-traumatic stress, depression, and anxiety, and just better general mental well-being as compared with younger or middle-aged adults. So again, that's taking all these different studies and all thousands and thousands of people just looking at groups as a whole. The research suggests that older adults are doing a little bit better with their emotional well-being than other age groups. But I do want to point out there's some really important considerations with this research, because I think some of these studies kind of make it into the newspapers and things like that. So one thing to know is that most of this research, is because of the nature of the pandemic, has been focused on older adults who live in the community and are comfortable with using technology. So a lot of the studies that have been done have been like questionnaires that people might fill out online. So it might be missing the experiences of some older adults who could be living in long-term care facilities, or older adults who maybe aren't comfortable using technology or just don't have access to the internet. I think the timing of the research is also really important. So, it takes a while for people to collect data, put it all together and publish it and kind of get the information out. So a lot of the research that we have right now is really based on people's experiences last year and earlier on in the pandemic. And I know I've experienced it, and a lot of my patients have experienced a change over time in how we are responding to the pandemic. So I'm not totally sure that the results from the beginning of the pandemic are still completely relevant today because we've all been dealing with this for so long now. So it's not clear how much those earlier studies kind of translate into experiences now. And then just the final thing to note is that there can be differences in the experience of mental illness. So I mentioned before, in older adults, it's more common to see irritability and agitation as part of depression as compared to other age groups. And older adults might have more physical concerns, aches and pains and things like that associated with depression versus people in other age groups. And just sometimes how we describe our own experiences might be different. So some of the standardized questionnaires that we use to measure things like anxiety and depression maybe use different language that doesn't resonate as well with older adults. So they might be missing some of the experiences that older adults can have with depression. So if you are having any of these experiences, how do you know when it might be useful to get help? Maybe you've been trying really hard on your own to do all the things that you know to do to cope with anxiety or depression or loneliness or stress. Um, so something that we look at as mental health clinicians to kind of determine someone's level of distress is we look at the quantity of symptoms. So how many different symptoms of, say, depression is someone experiencing? How often are they experiencing those symptoms? Is it just once in a while, or is it, kind of everyday constant? How intense are the symptoms? Again, I mentioned with anxiety, is it just a little bit of worry, or is it kind of like a full-blown panic attack? And then how much do the symptoms interfere with someone's daily activities, their responsibilities, their relationships, and things like that? So those are just some of the things, when I'm getting to know someone when we're starting psychotherapy, that those are some of the things that I look at to see, how much is someone experiencing, depression, anxiety, whatever it might be. So I came across this slide recently that might be hard to read on the handout. So hopefully you can read it well on the slides on the screen. This chart was from a website for healthcare providers in Colorado, but I thought it did such a nice job of summarizing kind of how to tell where I am on this spectrum of, from the kind of the green column, thriving, I've got this, I'm doing pretty well, all the way up to I might need immediate help right away, kind of in the red column. So, a lot of the folks who are in outpatient once a week, once every other week psychotherapy are kind of in the yellow and orange range, I would say. But if you're looking at this red column and saying, oh, those actually look a lot like what I'm experiencing, I would say for sure that is a sign to get help, professional help sooner rather than later. But I would say even if you're in the yellow zone right now, it might be useful to reach out for professional support. And I just say that because, again, a year and a half into this pandemic, most therapists that I know are really booked up and are quite overloaded with their caseload. And some people have long wait times to get in, to take on new patients. So the sooner that you're able to reach out to a mental health provider to get help, the better off you'll be, because you might have to wait weeks and sometimes months, depending on the situation, to get help. So, again, just wanted to offer this as kind of a way to gauge, how do I know if it would be useful to reach out for help? I would say in the yellow and orange zone for sure, start reaching out for help. The red zone is sort of, okay, I need to get help kind of pretty much immediately. And so if you are kind of feeling like maybe it would be useful to get help, how do you go about doing that? So one thing that's really useful to do is if you have a primary care provider, it might be really useful to reach out to that provider. A lot of primary care offices these days have behavioral health clinicians, and those are mental health clinicians, psychologists or social workers or counselors who are located in the clinic, who very often can see people for short-term help. And so that might be if you're in that yellow zone and maybe you're noticing, gosh, I'm really starting to have some trouble sleeping. That might be a really good resource. They're usually short-term things for very specific mental health problems that again, it's helpful when the provider's in the primary care office and they can collaborate with the medical professionals. And they can also provide community referrals. So if, maybe you can have 6 sessions with a behavioral health provider, and if you need something more beyond that, then they can help you to find therapists in the community as well. It can be really useful to check in with your insurance company. They usually have a list of providers that are in network. If you're able to see an in-network provider, usually you have lower co-payments. But these days, because it is really hard to find a therapist with openings, it's also useful to ask if you have out-of-network benefits with your insurance company. That would kind of broaden the reach of therapists that you might be able to work with. Usually those out-of-network folks, you'd have a higher co-payment for them, but each insurance plan is a little bit different. So it's useful to ask both the in-network and out-of-network benefits for mental health services. I would also encourage folks to be willing to work with clinicians in training. So I mentioned I supervise a graduate student in my practice who's with me 1 day a week and has great experience of doing therapy under his belt, but just wanted to get a little bit more before he finishes his graduate training. And our local universities have clinics where they have students who are providing psychotherapy. So Pacific University, PSU, I believe, has a clinic as well. So, thinking about, working with a graduate student or an intern can be a good option, especially if it helps you to get in to see someone sooner rather than later. And then I put a couple of other resources here that I thought would be useful. That's not necessarily psychotherapy, but just kind of other resources for support. The first one is the Oregon Senior Peer Outreach Program. That's something that had been started before COVID, and actually did a pilot program that showed that this peer outreach program decreased loneliness and increased life satisfaction for the participants. So this is where it's a weekly telephone support program for adults aged 55 and older who might be experiencing depression or loneliness or isolation. And they meet with trained peer support specialists for these weekly support calls. It had originally been for our more rural counties, but since COVID, I believe they have expanded it to anyone who lives in the state of Oregon. And you can reach out to that program yourself. I've included the phone number here, but they have a website as well that you could go to get more information. And I believe that they also do have electronic referral forms for healthcare providers. So that would be another way to be able to access that program, is have your primary care provider or one of your other providers fill out a referral form for that. And I believe there is no cost associated with that program. The other one is the Senior Loneliness Line. And again, that was something that also started before COVID, but has expanded during the pandemic. And this is kind of what they refer to as a warm line. So it's not a crisis hotline. It's more for people that maybe are not experiencing crisis, but just feel like they need a little bit more support or some resources, just someone to listen. And this is for adults age 55 and older, again, across the state, who might be experiencing loneliness or isolation or depression or anxiety. And translation services are available. So if someone isn't comfortable speaking in English, there are opportunities to use other languages. And the Senior Loneliness Line is associated with our local crisis hotline. So if someone does call and they are in crisis, these the folks answering the phones are able to handle those situations as well. But again, this was a line specifically designed to support older adults and linking them to resources if necessary. The next one is the Safe and Strong Helpline, and this one is provided through the Oregon Health Authority to people of all ages across the state. And if I believe their website is just safestrongoregon.org. So if you're able to use the internet, they've got tons and tons of resources on their website, but they also have a number that you could call and again, get some additional support and get access to community resources. And then the last one that I've listed on here is the National Suicide Prevention Lifeline. And this is a free, confidential 24/7 phone number that folks can access, particularly if they're having thoughts about wanting to harm themselves or commit suicide. This is something that it's a network of local crisis centers. So anyone in the country can call this 1-800 number and get connected with their local crisis center. And I believe they also have a chat feature. So if people are more comfortable chatting online, that is another way to access these services. And I think they used to have a text option as well, but I'm not 100% certain on that. So they've got different ways of kind of interacting with those support resources. And I should mention too, I realized I didn't include this on the slide, but Parkinson's Resources is another resource. I know that they're really great with connecting people with local resources as well, and sometimes can meet with people kind of short term for emotional support. So I apologize for not including that on the resource list here, but it's certainly an important one. So for the last part of the talk today, I just wanted to talk a little bit about what to expect from psychotherapy. And I wanted to mention this specifically, if you haven't had experience with psychotherapy or counseling in the past, it can be kind of intimidating if you're not really sure what to expect. So generally, when you contact a clinician, in private practice or an outpatient clinic, usually they'll schedule an intake interview or an intake session where they'll ask you questions about your background and what kind of mental health symptoms you might be experiencing currently, and kind of what your hopes are for what you'd like to accomplish through psychotherapy. That can take anywhere from 1 to 3 sessions, kind of depending on the person's situation and the clinician's process. But usually it's 1 to 3 sessions. That's kind of an intake process. And the therapist might also share a little bit about how they work and what their initial treatment plan might be. One really important thing to evaluate during the intake process is the goodness of fit between the clinician and the patient. Research has found that one of the most important things in making psychotherapy successful for people is that match between the clinician and the patient. So you really want to be able to work with someone where when you talk with them, you feel comfortable talking with them, you feel understood and respected and listened to. So that's an important part of the intake process to see that, if you really feel good in talking with the clinician, and also for the clinician to feel like they're able to help you with the issues that you're dealing with. Right now, lots of therapists are offering remote sessions, so meeting online where you can see and hear the clinician at the same time through a website like Zoom, or telephone sessions sometimes are an option. Some folks are doing in-person sessions at this point, and there's kind of pros and cons to both ways of doing therapy. But research has found that doing remote sessions is just as effective as doing in-person sessions. So I think especially early on in the pandemic, people weren't sure if remote psychotherapy was really going to work, and all the evidence suggests that it is very effective and very helpful for people. In-person sessions can be really useful too, but just to know that healthcare providers, as healthcare providers, we still have to wear masks. And I have found that to be a challenge when I'm meeting with folks in person, that I only get to see kind of half of their face, which is kind of a challenge in psychotherapy. So again, pros and cons for both. Um, and something to just know is the length of treatment can vary depending on what someone's dealing with. So, and that's something that is kind of evaluated in the intake process as well. You know, sometimes when I'm working with people, sometimes someone just needs kind of a handful of sessions and their issues are sorted out and they're feeling, you know, good to go on their own, all the way up to there's folks who I've been working with off and on for several years at this point. So that's something that would be important to talk with the clinician about if you are doing the intake process, of just how long do they think it might take for you to be able to benefit from psychotherapy. Just a couple other things to know is that in the state of Oregon, most psychologists, social workers, and counselors do not prescribe medication. So medication would be, you know, prescribed from a psychiatrist or a nurse practitioner, but not psychologists or social workers or counselors. But many therapists are willing to collaborate with your medical providers. So very often I am in touch with my patient's primary care provider or psychiatrist to help kind of collaborate and kind of help people, you know, kind of benefit from their medications as much as possible, but I'm not the one prescribing them. And another thing to know is that sometimes individual psychotherapy can include family members in sessions. And I have found this particularly helpful when I'm working with people with Parkinson's. If they have a care partner, it's usually a family member, it can be really useful to have that person come in a session or two, just for me to get their perspective on how the person is doing. Especially if someone is having any problems with their memory, it can be really useful to get information from the family member as well. And that's, of course, only done with the patient's permission, to bring in a family member or a care partner into those sessions. So just wanted to mention a little bit about the different kinds of psychotherapy. So just to know that psychotherapy or counseling are kind of used interchangeably, and they're kind of an umbrella term for lots of different kinds of psychotherapy or theoretical orientations. This picture that I have on the screen here is from cognitive behavioral therapy, or CBT. That's a pretty popular one that a lot of folks have heard of, and a lot of medical providers have heard of as well. So sometimes they'll refer people for CBT, but that is just one specific kind of psychotherapy. And it really looks at, it really helps people to change negative or unhelpful thinking patterns and behaviors in order to improve their mental health. So just the idea that how we think and how we act affects how we feel. And CBT is something that's usually focused on someone's quality of life right now. So it doesn't spend a lot of time looking at someone's, you know, childhood experiences and things like that. It might come up if those experiences are directly affecting someone's emotional well-being right now. But generally, you're focusing on what's happening in someone's life right now and helping people to make changes in their thinking and their behaving in order to make changes in their emotional well-being. And CBT is typically shorter term. So, you know, around 20 sessions or so is pretty typical. But again, there can be a lot of variety in that. So if you've heard CBT, all that's referring to is that's a specific kind of psychotherapy. And other kinds of psychotherapy that I use in my practice and have been shown to be very effective for people age 60 and older, and people dealing with medical issues. One is acceptance and commitment therapy, or ACT for short. There's a lot of similarities between CBT and ACT. So it focuses on thinking and feeling and doing. But the emphasis is really on, instead of changing our negative or unhelpful thoughts, it's more about changing our relationship to our thoughts. So sort of not taking our thoughts so seriously, in a sense. And I like using ACT, especially with older folks, because there is a lot of emphasis on what's important to someone and how can we help them live their lives congruently with what is important to them, even in the context of limitations. Say if someone has medical issues and has limitations, it's not just about how can we get rid of symptoms of depression. It's more about what really matters to me and how can I do those things that matter to me, even with some of the limitations that I might be experiencing. The other ones I've listed here are problem solving treatment, reminiscence therapy, and then creative arts therapies. All, again, have slightly different ways of helping people with their emotional well-being. These can be particularly helpful for people that might be having difficulties with their memory or their thinking abilities. So CBT and ACT can rely a lot on kind of people remembering things from session to session and kind of doing homework in between sessions. Whereas problem solving treatment, reminiscence therapy, and creative arts therapies don't necessarily rely on kind of memory so much, or in a way that it can be helpful for folks that may be struggling with their memory or thinking abilities. And that's something you can ask a therapist when you meet with them for the first time, or even talk with them over the phone. What type of psychotherapy do they do? They should be able to kind of generally give you an idea of their approach and how they work in psychotherapy. So I'm noticing I'm exactly on time. It looks like it's 12:45 on the dot. So I'm impressed. I was able to do that. So we wanted to leave some time for lots of questions and discussions. So that's all the information I wanted to provide in the presentation, but I'm certainly happy to ask or answer any questions that people might have.